I'm Brittany with Birth It Forward, certified birth and bereavement doula, certified yoga instructor, and family photographer.
Hi, I'm Kristen Mason. I'm also with Birth It Forward. I am a certified birth, postpartum, and bereavement doula, a childbirth educator, and a student midwife. And today we are going to be doing a series on induction. Don't forget to like and subscribe so you never miss an episode. And let's get ready to hear from some doulas who know squat.
All right, welcome back. Today is the talk about induction from 1 to 3 centimeters. We ready?
I'm ready. Let's do it.
Okay, so if you have been watching our series, then you know that in the last video we talked about induction from 0 centimeters, and we ended on talking about catheters and inserting things into the cervix to help it dilate. Let's talk about those things of a Foley versus a Cook catheter.
Let's do it. So I have great news for you. They tend to be equally effective.
Yeah.
So that's helpful. So a lot of hospitals are only going to carry one or the other.
Yep, I see Foley the most. I don't see a lot of Cook.
Mhm.
The Foley is I always get them confused. Foley is 2 balls and the Cook is 1, or is it the opposite?
Other way around.
Okay, yeah, see, I always get them confused.
Mhm.
Foley has the 1 ball, and that is the ball that goes inside the cervix. So you put the catheter, or here's your cervix, right? You put the catheter through, and then say, this is your uterus. Well, the ball has to expand on the inside. Can you tell? I don't know. So the ball expands on the inside to put that pressure on the cervix to make it expand, to make it dilate. That is the whole premise of either the Foley or the Cook.
Mhm. Yeah,
Would you like
it's
to explain
using,
the Cook?
and I talked about this a little bit earlier, but I'll reintroduce it in case anyone hasn't seen our other videos. And if you haven't, you should go watch them. Um, it's the Ferguson effect, pressure on the inside of the cervix that causes it to start thinning, softening, dilating. Ideally, this would be done by a baby's head.
Yeah.
However, most of the time at this point, baby's not super low. That actually can be something that is taken into consideration if you're deciding whether or not you want to do a Foley or a Cook catheter. Is my baby low in my pelvis? If you have a baby that's at a 0 station, putting in this ball that's full of saline will then push the baby back out of your pelvis, which is something that you might want to think about of if I've already done this work to get baby down. And that's one of the really big goals in early labor is to get a baby down into your cervix. Do I want to be putting something in that's going to push them back out? And then I'll need to bring them down again. And especially if they're down in a good position and I might push them up and kind of tilt their head in the process and then they come down asynclitic where they're not lined up very well for coming out. That might be something that you want to talk to your doctor about and see where we're at. That increases your risk of what's called a cord prolapse because we're lifting baby up out of the way. Their cord can then come down and then the cord comes through your cervix before baby. And that is an emergent situation if that does happen. So these are things to kind of think about when we're discussing this. However, if your baby is already a floaty baby and there's already room for this, then maybe it's a really good option for you. What's someone expecting if they get one of these inserted?
Pressure. There's a lot of pressure with these.
Mm-hmm.
Because it's not baby, it's an artificial pressure. Something else to think about is they only go to 4 centimeters. So once you are at 4 centimeters, they naturally will come out on their own. It's
Mm-hmm.
almost like if you have a full tampon and it starts to slide and slip,
Yeah,
it's
it's
just going to
exactly
kind of,
like that.
yeah, it's just going to slide right out. And you'll be like, hey, nurse, something's happening. It's just the Foley or Cook catheter coming out. No big deal. That's a great thing. It means you're at 4 centimeters. However, it is not a natural 4 centimeters. Kristen and I were actually discussing this earlier. This is a manual 4 centimeters. So it is very possible for your cervix to close back up a little bit and be considered more of a 3 than a 4, even though the catheter went to a 4 and it slipped out. So
All
it
that
could
stretch into a 4 or a manual 4. It's
yeah,
different.
it is very different.
Mhm.
because it does have that ability to come back. But it can do that even, I mean, I had a mom who was considered 9 centimeters. They broke her water and the very same thing happened, but that's because the water was putting that pressure and opening the cervix. And then when that pressure was gone, it closed back up. So it can do it at these
To an
early
8,
stages,
right? Is that how far down it went? Did it go
7,
further than that? 7. Ouch.
it's down to a 7. Yeah.
Oof.
It might have been a 6 even. I don't, it was heartbreaking
Can be
for
kind of
all of us.
dramatic.
It was.
Yes.
But anyway, I'm just explaining that that is a process that can happen at any point
Mhm.
in your labor. That cervix can close back up a little bit.
Mm.
So
Just not at actually closing, by the way.
yeah,
The cervix is the same amount of ready for a baby to come out um, when it's being stretched and when it's not being stretched, because once the baby's head is pushing on it, it is stretched. But if the
yeah,
baby's head is not pressing on it, then it is not. So it's a very interesting dichotomy that we kind of measure. But in the end, the cervix does need to be out of the way in order for the baby to come out. That's the goal here. The goal isn't to get centimeters. That's just how we represent how we're getting closer to baby actually fitting, right?
yeah,
So it's always
yeah,
very interesting to think about what's the ending goal here. The ending goal is not get to 10 centimeters, which is actually not even accurate for how much you dilate, but we'll get to that later. But the
right.
goal is to get dilated to the point the baby fits, which is going to apply pressure. So you'll get back there. No, so don't be discouraged. But it can actually be quite helpful to know this in the conversations that you're having with your provider about where you're at and different decisions that you might make when
Absolutely,
one of those fall out.
absolutely.
Yeah.
So in conjunction with a Foley or Cook catheter, you know,
Hmm.
they probably already did your cytotech and or Cervidil.
Hmm.
And now we've applied the Foley or Cook
Hmm.
once you hit 1 to 2 centimeters. So you've had this
Hmm.
applied for a little bit.
Yeah.
Baby's still going to be a little high.
Especially if you
And
have that, the baby is definitely high if you've
yeah,
got a Foley or a Cook catheter
you have
in.
enough room to put that in. Yeah.
Exactly.
Yeah.
We're going to be at least
Um,
this high.
yeah. Now, is it recommended to do nipple stimulation?
By me.
A lot of
Do I
times,
recommend it? Yes. But you're going to need to talk to your doctor,
yeah,
or your midwife or whoever. When I am in the role of a student midwife who is able to support somebody, maybe they've been a transfer because something has happened and they need induction and they're talking to me about their options, then would I say nipple stimulation is going to help you out? Absolutely. The main thing that we're looking at is how crampy are you? We don't want to overstimulate your uterus. We're looking for cramps, but we're not looking for cramps that never stop. We don't want to wear your uterus out. We want it to be, and at this point, we're stimulating early labor. So these contractions that we're looking at should be short and pretty far apart, right? With the Foley or with the Cook catheter, you are going to feel like you have been pushed into active labor. Those contractions tend to be longer and closer together. So that's a coping thing to kind of think about. And so if you are coping well with that effect, that pressure, nipple stimulation could be really awesome for you. What I really don't want to see is you getting pushed to the point of discomfort that you opt for an epidural, because like we talked about in our last video, it's not that I'm anti-epidural, it's that it's not a good idea to get one at this point. It's too early. You'll be having this epidural for too long. So there's some nuance in there of, do I think that it's a good idea or not? For most people, great. Um, but it's going to depend on how you're coping. It's going to depend on how often your contractions are and how intense they are. And then kind of keeping in mind that once that puppy falls out, your contractions might stop
they
because
might.
there is nothing pushing on it anymore. So you might have this really good escalation with a lot of contractions that are making a really good difference, and your body feels like it's really going, and then it falls out, and then
We just stall.
we have this nice big break. Um, Also keeping in mind, I did want to make sure that I mentioned this of as far as expectations go, you should expect to bleed when you have a Cook catheter or a Foley catheter inserted because the dilation is going to be happening quite quickly. And so the blood vessels in your cervix do break. And so then there is some blood, not a ton of blood, but especially if you've got the Cook catheter where there's a ball inside and a ball outside, the one on the bottom comes out looking like an apple because it's not, it looks like a lot of blood because it went in transparent and it comes out red, but it's just because like a drop would look like a lot on that.
Yeah.
So you should be expecting some bleeding there.
Yeah. I mean, anything that you're going to be doing inside like that has that potential to bleed.
Mm.
So with that in mind, should they be doing Pitocin at this point?
Oh, no,
It's really early for Pitocin. Your
still
body is
very early.
still preparing. It is still working through what labor even means to your body.
Mhm.
We're barely dilated at this point. We were barely dilated enough to put a catheter in if you chose to go that route. It is definitely not at the point where your body is ready to fully dilate to begin that dilation process because we're still thinning. We're still working on, can I dilate? So
Yep.
preferably
The-
no Pitocin right
Yeah, the use of Pitocin at this point would be using it off-label. It is not FDA approved at this point, 1 to 3 centimeters to be giving you Pitocin. Now, this is a conversation that you have with your doctor, of course, and we don't know your situation. So it might apply to you that we need to get this baby out ASAP, and maybe they think Pitocin is going to do it faster, or you know something about yourself that we don't. But in general, no.
now. All right. You are still in early labor here.
Mhm.
This is 1 to 3 centimeters. Active labor is at 6 centimeters and 6 to 8 centimeters.
Mhm.
So you are still early. You can
Mhm.
stop. That is okay. You can
Mhm.
slow it down if you need a break.
I like to use finger quotes when I say it because at this point, what's a stall,
Yeah, what's a
right?
stop? There's a stop. Your body
Early
is
labor, if done without intervention, can last for weeks. There's a reason that we tell you to pretend that you're not in it because you can get mentally exhausted well before you get physically exhausted. You can sleep through early labor. We encourage it, right? A lot of
absolutely.
people don't even notice that it's happening. They go in for their OB appointment. The OB goes, "Oh my goodness, you're 4 centimeters. How have
And
you
you're
been
like,
feeling?"
oh,
Great. No, I had no idea.
yeah, yeah,
Right? So that's probably not going to be the case in hospital. You'll probably feel something because we have less of the natural hormones happening. Natural oxytocin really helps us to not feel it as much.
yeah.
But
But
we still
we're
have
also
that same,
interesting it.
right. We still have that same mentality of early labor can last a very long time, and that is natural and totally normal. Now, if you're in a situation where the baby needs to come out soon and the baby needs to come out soon, that might change your conversation a bit. It's more nuanced than that. But it would have to be a pretty emergent situation for it not to be viewed that way.
Absolutely. Um, we're in early labor. Like she's saying, we have no expected timeline right now.
Mhm.
Early labor varies from person to person and even from pregnancy to pregnancy. You might have a 3 week long early labor for one pregnancy, and you might have a 2 day early labor for the next pregnancy, or essentially no early. I mean, that's not really going to be the case. You're going to pretty much have an early labor. You just don't realize you're having it, or you
Mhm.
might go early labor, prodromal, early labor, prodromal, you know, like I did, which is always fun.
Prodromal is
Um,
different from early labor for people who don't know because it does not make cervical change. So you
yeah,
feel it, but it makes no difference in your dilation or your cervix. If it is making difference in your cervix, it's early labor.
yeah, and it mimics labor.
Very
You
well.
can think, yes, oh yeah, because it's steady. Ah. But anyway, you are still in early labor, so we don't have an expected timeline. It can It goes however long it takes.
Mhm.
However, if you're in the hospital, they do have a timeline.
Mhm.
You don't. They do. Usually it's within a 12 to 24-hour time block that they want you to go from early labor into an active labor state.
Yeah.
So that is something to keep in mind. If you're starting to hit that point of you're at 12 or 24 hours and you're still well into your early labor stages, maybe you can just go home, take a break,
Mhm.
relax, let your body absorb all of these things that have been going on
Mhm.
and take the stress out of it. Because
Mhm.
at that point, we're going to start seeing some more interventions. If you have the ability to go home, because not of medical reasons, so if you have that ability, just take it out. It's
Yeah.
just
People might be thinking, what kind of situation would turn into that? Quite a few, actually,
yeah.
especially because a lot of inductions happen because of a failed NST test, biophysical profile that's not looking good. So they have you come in because they say baby's not doing well. And then they put you on monitoring for 24 hours and baby's doing wonderfully. Oh, well, then baby's good. I guess we can go home then.
Yeah.
um, things of that nature. They happen every day. And I like to encourage people to kind of have that mindset going in of being ready to make adjustments. Labor is all about surrender, right? So maybe we're surrendering to the thought that, oh, I wasn't expecting to go in for an induction today, but baby's looking like they need to come out, so I'm going to go do it. And then you get very excited and you get there and you're prepared to have your baby. And
Mm-hmm.
then, oh,
Nothing happened.
the situation has changed. I guess I'm going to go home now, and to be able to adjust to that, and make that decision for yourself. And sometimes going home and getting out of that environment, the sterile beeping environment of the hospital, especially for people who don't like hospitals, getting those monitors off, you go home and you go into labor and
Things
you come
happen.
back. It
Yes,
happens. It does. I've seen it many times.
many times. Yes.
It should be
Now,
very
there are
encouraging.
people who are more comfortable in the hospital,
Mhm.
but you're not going to see those slowdowns early on like that. You're not going to see the slow build as much in someone who's more comfortable in a hospital setting than someone who maybe you were planning a home birth, or maybe again, like Kristen's saying, we went in for our doctor's appointment, we failed the NST, and now we're here all of a sudden. That's a lot to process, and no one's helping you process it. So
Unless you have a doula
take,
or a really
yes,
well-educated partner, or the birth floor is really, really slow. And so your nurse has time to hang out with you.
yes, there are many reasons, but if you're able to process it, going home can help you process it. Take that break if you can. Especially if baby's doing really good on the monitor and we don't have any concerns at this point. I mean, you're probably 38, maybe 39 weeks. Maybe you can stay in there another week or two if we need to. And your body will begin, it'll say, okay, I've gotten some things in here that are saying I need to get started. And it's going to say, okay, I'm going to get started. I'm going to start these things.
Yeah. Something that I always like to encourage people with is once you make progress, that progress is not lost. Even when we were talking about if the Foley comes out and you lose some dilation, you're not actually losing dilation. It's the measurement tool that is flawed, not you. And you
Absolutely.
don't go into the hospital and get these induction methods done and then lose it by going home. Um, Now, if you are on Pitocin, if you turn it off, it has to be slowly turned back on. And sometimes that's presented to you as a loss of time because you have to slowly get back up. They can't have Pitocin at a 20 and then turn it back on a 20. They have to start at 2 again. And that's a drip measurement. Um, but that's still not a loss. You didn't lose the change that was made when you had that medication by turning it off. You're pausing it and then seeing what your body does with it. It doesn't go
Yes.
away.
No, and oftentimes when we turn it off, your body's going to continue that pattern. It's just going to do it naturally and give you a little break here and there
Mhm.
and give you that chance to recuperate from the intensity that the Pitocin caused so that your body can naturally continue on with that labor in an easier manner.
See what your body does with it. It's an option.
Yeah.
Speaking of another option, what about membrane sweeps?
Yeah, those are always an option as long as you can get a finger in. So if you're 1 to 3 dilation, now you don't have to do a membrane sweep in the hospital. Maybe you are dilated at 2 centimeters for the last month and you're like, okay, I'm getting close to my due date, or I'm past my due date is more likely. And you can ask for a membrane sweep, or the doctor might say, hey, what do you think about a membrane sweep?
A prenatal visit.
Yeah, yes, at a prenatal visit.
In
Yeah,
clinic. You're not
and a
doing
clinic.
this at home to yourself. Please don't.
No, don't. Yes. There are some definite concerns with membrane sweeping. Your
So many.
physician, yes, your physician or your midwife would need to do this, not you. And then you would do this at your visit. They have the option to do it if you have done, your Cytotec or Cervidil, but chances are they're not going to do a membrane sweep after one of those, since your cervix is pretty tender potentially after Cytotec or Cervidil. So this is one of those things that maybe you're dilated to, you guys are starting to talk about an induction, and this is the first step you want to take before you even go fully or anything like that.
Yeah,
So,
with that in mind, if you are getting a cervical check in clinic and you do not want your membrane swept, it's a good idea to let your provider know before they go in, because some providers do them as just part of the process when they're checking once you hit a certain number of weeks, and that number of weeks changes per provider. You're not supposed to do this without asking for permission, but it is not uncommon. It's not something that we see rarely. It's something we see more often than we would like.
and a lot of times they don't even know they did, honestly.
Yes. Sometimes, depending on how gentle they are,
Yeah.
you may or may not feel it. So, how does this work? It's going to feel from a lot of people exactly the same as a cervical check, but a very long one. The idea is that ideally a provider is able to get 2 fingers into your cervix, and depending on if they have man hands or not, it's going to kind of change how dilated you need to be for that. And I have very thin fingers. I'm able to actually get both of my fingers in if I am very careful and kind of work the cervix open a little bit. If you're dilated to a 1.5, I can do that. It's very slow. I am very gentle and careful. I never want to hurt somebody. If they're uncomfortable at all, I take my hand out. But for some people, their fingers are larger than that. Some people that do these cervical checks, my 2 fingers is the size of their one. They're going to need you to be dilated a bit more in order to be able to do a true sweep. If someone can only get 1 finger in, what they're going to do is they're going to bend it and they're going to do a circle around the just inside of your cervix. Now, some practitioners, to kind of help with that, they'll actually put their hand on the top of your belly, get right up on the top of that fundus and push down to kind of push baby's head onto the cervix to help give them that pressure to actually help you dilate a little bit more so that they can get further in and have it be more effective. It is still a membrane sweep if they're only able to get 1 finger in, but it doesn't work as well. So if they can get 2 fingers in, then what we're going to do is we're going to take it, we're going to put it in, and we're going to do this as much as we can and spin in a circle. And you're going to really gently try to irritate the inside of that cervix, push on baby and all of that jazz. The balance being you want to be gentle enough that you don't accidentally rupture someone's water, because do we want water ruptured at this point, Brittany?
No, absolutely not.
No, we don't. Your water
No.
might have already ruptured, which might be why you're getting an induction, right? So that might not be
Right.
something that you get to have a say in. But if it's not, then we don't want to accidentally, it's called artificial rupture of the membranes, AROM. So we don't want to AROM you, especially without your permission, and try our best. Some of those water sacs are not super thick anymore because you're getting ready to give birth and they're supposed to break. They're just not supposed to break quite yet. Would you prefer for it to rupture on its own or I prefer for my clients to rupture on their own for many, many reasons. Some people do choose to have their water broken at many different points. I've even had a client that wanted to have her water bag broken to start her labor, to start at the very beginning of her induction. And you weigh the risks and make that decision, but your bag should not rupture due to a membrane sweep if they're being careful enough. But that's how that
Absolutely.
works. That's kind of what to expect.
Yeah. So with that in mind, as she said, breaking your waters is an option to start your labor or to have your labor continue in a stronger manner, potentially.
Support.
However, yep. However, with breaking the water, we're starting our time clock because now we have a much higher risk of infection happening. We are also making it to where you can't stop this labor. You have to continue, even if you decide 5 hours in, you haven't made as much progress as you'd like. We can't stop it and go home and take a break. You're in it. You can't leave. Your water was broken. Something else to think about with water breaking is those contractions become more intense. Think of it as a big water balloon that your whole uterus is a big water balloon. And it's taking all of that contraction and kind of boinking it. It's spreading that contraction around more evenly. And if that water balloon doesn't have it, then it's going to, it's more of a squeeze, like a,
Yeah. That was great sound. I think of it as a water bed versus a
yeah, there you go.
mattress. If you jump on a water bed, whoom, whoom, it kind of
Yes,
spreads out. It's not all in one place. You jump on a
you're gonna know
mattress, it's
it's
much
right
less
there.
so. There's some bounce, but it's much less
Yes,
so. Kind of more of the feeling of it. One is much more flowy and the other is much more solid.
yeah. And you may not see the difference. You won't, well, I mean, you won't really see the difference, but you're going to feel some of that difference. Those contractions without the water are going to be a little more intense. So I have a lot of clients who maybe we get to 4 or 5 centimeters and they've broken their water due to recommendations or whatever, but at this point, they're like, oh, I don't know that I can handle these anymore. It's the same contraction. The only difference is we no longer have water helping to support that contraction.
Right.
So when
Yeah.
we're talking breaking waters, we also have to talk about, we're going to intensify this. What can we do to help work ourselves through this higher intensity level?
Yeah. If your water is broken, can you get into a tub?
Yeah. At the
If you
hospital,
can,
no. At home, you can.
it depends on the hospital.
Absolutely.
And the thing is, for all of these things, when it comes to let you do, I love using finger quotes for so many things in this. To a certain extent, you can just say, I am an autonomous adult who is making decisions for my own self. And then tell them that you accept the risk of getting into water.
They may
There
have you
are
sign
so
paperwork.
many studies. There's a brand new one that just came out talking about the safety of laboring in water when your water has
Is it
broken.
favorable?
And you know what? I love it. I shared it all over the place, sent it to everybody because I am a huge water birth fan. I think that it is
Same.
amazing,
It's incredible.
fantastic, and does a lot of the things that I'm looking for my clients to get to experience during their labor,
Yes.
that I myself prefer to experience in my labors. And so if you are planning on having your water broken, it would be very good to have that conversation with your provider beforehand of, do you or do you not want to get in the tub? If they're not a big fan of you getting into the tub, maybe some compromise of just getting in the shower,
Yeah.
you
I mean,
know?
the shower is still comforting and relaxing. It's not going to have the same effect as a tub, but the water still has a very similar effect. I know I love the shower when I'm in labor.
Keeping in mind,
Most
it
of the
can
clients
speed
are
your
great.
contractions up.
Yes, because
A lot
it's
of people don't know
relaxing.
that. Yeah.
Yes,
Getting in a tub can slow them down. Getting in a shower can speed them up because human bodies.
yeah. Or getting in the tub can speed them up if you're at a higher level of in your labor.
It helps you to relax. When you let
Yeah.
go of relax, relax, relax throughout your whole labor, the goal is to relax your pelvic floor. And so if getting in the tub helps you relax your pelvic floor, then it's going to help your labor progress.
Absolutely. And now something we haven't talked about is bringing baby down. I mean, we've talked about it a little bit with Foley and Cook, but if you don't have that in there, baby's not engaged yet. We want baby engaged. There are lots of positions. We have videos on our sites that go over all of these positionings. So take a look at those and work through some of those positions to help bring baby down, whether that's bouncing on an exercise ball or that doing those squats or doing your tummy lift and tuck.
Love that.
Bring,
I love
I
lift and
know,
tuck
me
so
too.
much.
You hate them when you're in labor, but oh man, they do the work. They get it done. I
Worth it.
almost punched Darcy. Making me keep doing those. I'm like, no, I need to stop. Okay,
I
okay,
can
fine.
picture that. It's forever living in my brain now. You and Darcy showdown of her.
Looking it up. But bring baby down so baby can put that pressure on the cervix, which is going to help it expand as it thins out. You want that pressure, which is what the Foley and Cook catheters are doing artificially. So you want baby to do that, which also helps reduce the risk of the cord prolapse and over loss of water and all of that stuff. So da-da-da-da.
Yes, your baby's head works as a plug. So when your water breaks, then when it hits your cervix, then the water stops draining out quite so much, which can help it not be quite so uncomfortable. And also your baby is used to being in water. We like them to have water.
They like water.
We like for that plug to keep the cord from going through. We also like for baby not to suddenly drop onto your cervix. We like for them to have already been close to it when your water breaks, if not almost directly on top of it. For the same reason we were talking about in our earlier videos, asynclitic baby, which means a baby coming down with their head or their hands in a not ideal position. Are they looking up? Is their head tilted? Yeah, we joke that some babies like to watch themselves come into the world and see where they're going. Birthing this forehead, not much wider if you're looking at a human head than birthing it like an arrow. So that's going to be the preference, is that your baby's head is coming down straight. Babies are much more likely to throw their arms up in what's called a Morrow reflex if they are startled, such as suddenly having the water drained out from their home that has been water their entire existence that they remember. Arm gets thrown up, they look up, and suddenly we have a really asynclitic baby that's in your pelvis in this really hard to birth direction. So just getting maybe if you're discussing having your water broken at this point, one of the questions that you ask is, how low is my baby in my pelvis? Are we concerned that they're going to, and if you don't remember the word Morrow, just say throw their hands up.
Yeah.
Or move their head in a way that we don't like. Have this discussion with them.
Yeah, absolutely. That is definitely a discussion to have when talking about breaking waters at any stage. So
would it be more helpful for me to take a nap with a peanut ball?
Yeah.
If you don't know what that is, hit up your Googs. It's fantastic. We love peanut balls.
I have a video about the peanut ball.
Yeah, you do. Let's link that too.
Sure.
Let's link a million
We have
videos on
all
this
the
because we
videos.
have so many of them. I can't
We
even
have all
keep
the
track
videos.
of all the videos we have, and I love that.
I know. We have so many. That's what we do. We educate. All right. Well, I think
from
that
our hard work and education.
right.
Watch the videos.
I think that brings us to an end of our induction from 1 to 3 centimeters.
I think so.
So meet us in the next video about induction at 4 to 6 centimeters.